Hello everyone, this is the RNSG 2371 Exam 4 Review. The concepts covered will be metabolism, nutrition, health promotion, tissue integrity, mobility, and cognition. The first concept of metabolism includes, within all of your reading on the reading assignment list, diabetes type 1, diabetes type 2, gestational diabetes, hyperthyroidism with a focus on Graves' disease, hypothyroidism, hypercortisolism, which is Cushing's disease, and hypocortisolism, which is Addison's disease. The concept of metabolism concerning the exemplar diabetes mellitus, which is classified into different types. There is diabetes type 1, diabetes type 2, gestational diabetes, and diabetes associated with other conditions or syndromes. For example, a woman with gestational diabetes may, after delivery, move into the diabetes mellitus type 2 category. Prediabetes is classified as impaired glucose tolerance or impaired fasting glucose and refers to a condition in which blood glucose concentrations fall between normal levels and those considered diagnostic for diabetes. Now, insulin is the hormone secreted by the beta cells, which are one of the 4 types of the islets of Langerhans in the pancreas. Insulin is an anabolic or storage hormone, and when a person eats a meal, insulin secretions increases and moves glucose from the blood into the muscle, liver, and fat cells. In those cells, insulin has the following actions: transport and metabolizes glucose for energy, stimulates storage of glucose in the liver and muscle in the form of glycogen, and signals the liver to stop the release of glucose. Now, there are risk factors for diabetes mellitus. First is the family history of diabetes. Second, obesity. Third, race and ethnicity with African Americans and Hispanic Americans, Native Americans, Asian Americans, and Pacific Islanders. Age greater than 45, but that doesn't always consider the same as the type 1 diabetes mellitus. Previously identified impaired fasting glucose or impaired glucose tolerance tests, which has to do with gestational diabetes. Hypertension greater than 140 systolic. High density lipoprotein cholesterol levels or triglyceride levels, and history of gestational diabetes or delivery of a baby over 9 pounds. Now, within this type 1 diabetes mellitus, there are some symptoms, clinical manifestations that will be found. One is polyuria, which is frequent urination. Second is polydipsia, which is excessive thirst. And third is polyphagia, which is excessive hunger. These individuals will drink, eat, and urinate, and they don't understand why. It's because their body is asking them to do those things to get the glucose in their cells and energy, and it's not going to work. So they end up with weight loss, they end up with fatigue, and they end up with weakness. With type 2 diabetes, it affects approximately 90 to 95% of people with the actual diabetes disease. It occurs more commonly in young people who are older than 30 years of age and obese. There are 2 main problems related to the insulin in type 2 diabetes are insulin resistance and impaired insulin resistance. Normally, a person without disease, insulin binds to special receptors on cell surfaces and initiates a series of reactions involved in glucose metabolism. In type 2 diabetes, these intracellular reactions are diminished, making insulin less effective at stimulating glucose uptake by the tissues and at relating glucose release by the liver. Now, the exact mechanism that leads to insulin resistance and impaired insulin secretion in type 2 diabetes are unknown, although genetic factors are thought to play a key role. So the patient's pancreas continues to produce some endogenous insulin, and the insulin produced is insufficient or is poorly utilized by the tissues. For type 2 diabetes, obesity is the most powerful risk factor. For most patients, type 2 diabetes is detected incidentally. One consequence of undetected diabetes is that long-term diabetes complications such as eye disease, peripheral neuropathy, peripheral vascular disease may have developed before the actual diagnosis of diabetes is made, signifying that the blood glucose has been elevated for a time before diagnosis. Type 2 diabetes is associated with a slow progressive glucose intolerance, and its onset might go undetected, as I stated, for many years. If the patient's symptoms are experienced, they are frequently mild and may include the fatigue, irritability, polyuria, polydipsia, and poorly healing skin wounds, vaginal infections, or blurred vision if glucose levels are very high. Now, once again, this may be also the etiology and pathology from genetic mutations, as we stated earlier, that led to insulin resistance, and once again, that increased risk for obesity. For both type 1 and type 2 diabetes mellitus, the nursing and collaborative management care goal is to normalize insulin activity and blood glucose levels to reduce the development of vascular and neuropathic complications. The patient's goals are also for diabetes management to achieve normal blood glucose levels without hypoglycemia while maintaining a high quality of life. Therefore, diabetes management has 5 components: nutrition therapy, exercise, monitoring, pharmacologic therapy, and education. It involves constant assessment and modification of the treatment plan by health professionals and daily adjustments in therapy by the patient. Although the healthcare team directs the treatment, it is the individual patient who must manage the complex therapeutic regimen. Therefore, patient and family education is an essential component of diabetes treatment and is as important as all other components of the regimen. For both type 1 and type 2 diabetes, during periods of physiologic stress such as surgery, blood glucose levels tend to increase because levels of stress hormones, which are epinephrine, norepinephrine, glucagon, cortisol, and growth hormone, increase. If hyperglycemia is not controlled during surgery, the resulting osmotic diuresis may lead to excessive loss of fluids and electrolytes. Patients with type 1 diabetes are also at risk for developing ketoacidosis during periods of stress. During the postoperative period, patients with diabetes must also be closely monitored for cardiovascular complications because of the increased prevalence of atherosclerosis, wound infections, and skin breakdown. What must be maintained is adequate nutrition and blood glucose control to promote the wound healing. With clinical management of type 1 and type 2 diabetes, primary prevention is essential. It is also the management if you do have type 1 or type 2 diabetes. The areas of focus would be diet, exercise, and weight control. Nutritional, meal planning, and weight control and increased activity are the foundation of diabetes management. The most important objectives in the dietary and nutritional management of diabetes are control of total caloric intake to attain or maintain a reasonable body weight, control of blood glucose levels, and normalization of lipids and blood pressure to prevent heart disease. Success in this area alone is often associated with reversal of hyperglycemia in type 2 diabetes. For exercise, what the main goal would be is to manage diabetes because of its effects of lowering blood glucose and reducing cardiovascular risk factors with exercise. Exercise lowers those blood glucose levels by increasing the uptake of glucose by body muscles and by improving insulin utilization. It also improves circulation and muscle tone. Resistance training, such as strength training, weightlifting, can increase lean muscle mass, thereby increasing the resting metabolic rate. These effects are useful in diabetes in relation to losing weight, easing stress, and maintaining a feeling of well-being. Now, there are some considerations for exercise in people with diabetes. They can exercise 3 times each week with no more than 2 consecutive days without exercise. They can exercise at the same time of each day and the same duration for each session. Important to use proper footwear and, if appropriate, protective equipment. Avoid trauma to the lower extremities, especially in patients with numbness due to peripheral neuropathy. Inspect the feet daily after exercise. Avoid exercise in extreme heat or cold, and avoid exercise during periods of poor metabolic control. In people with type 2 diabetes who are overweight or obese, exercise in addition to dietary management improves glucose metabolism and enhances loss of body fat. Exercise coupled with weight loss improves insulin sensitivity and may decrease the need for insulin or oral anti-diabetic agents. Eventually, the patient's glucose tolerance may return to normal. For type 1 diabetes, the meal plan must consider the patient's food preferences, lifestyle, usual eating times, ethnic and cultural backgrounds. Patients who require insulin to help control blood glucose levels, maintaining as much consistency as possible in the amount of calories and carbohydrates ingested at each meal is essential. In addition, consistency in the amount time intervals between meals with the addition of snacks if necessary helps prevent hypoglycemic reactions and maintain overall blood glucose control. Blood glucose monitoring is a cornerstone of diabetes management, and self-monitoring of blood glucose levels has dramatically altered diabetes care. For type 1 diabetes, exogenous insulin must be administered for life because the body loses the ability to produce insulin. Consistently following a meal plan is one of the most challenging aspects of diabetes management. It may be more realistic to restrict calories only moderately. For patients who have lost weight, incorporating new dietary habits into their lifestyles, diet education, behavioral therapy, group support, and ongoing nutrition counseling are encouraged to maintain weight loss. In type 2 diabetes, insulin may be necessary on a long-term basis to control glucose levels if meal planning and oral agents are ineffective or when insulin deficiency occurs. In addition, some patients in whom type 2 diabetes is usually controlled by meal planning alone or by meal planning and an oral anti-diabetic agent may require insulin temporarily during illness, infection, pregnancy, surgery, or some other stressful event. People with type 2 diabetes who are overweight or obese, exercise in addition to dietary management both improves glucose metabolism and enhances loss of body fat. Exercise coupled with weight loss improves insulin sensitivity and may decrease the need for insulin or oral anti-diabetic agents. Calorie-controlled diets are planned by first calculating a person's energy needs and caloric requirements based on age, gender, height, and weight. Patients may be underweight at the onset of type 1 diabetes because of rapid weight loss from severe hyperglycemia. The goal initially may be to provide a higher calorie diet to regain lost weight and blood glucose control. The recommended level for caloric intake is 50 to 60% of calories should be derived from carbohydrates, 20% to 30% from fat, and the remaining 10% to 20% from protein. Carbohydrates. The caloric distribution currently recommended is higher in carbohydrates than in fat and protein. In general, carbohydrate foods that have the greatest effect on blood glucose levels because they are more quickly ingested than other foods and are converted into glucose rapidly. Carbohydrates consist of sugars and starches. Low glycemic index diets may reduce postprandial glucose levels. Therefore, the nutrition guidelines recommend that all carbohydrates should be eaten in moderation to avoid high postprandial blood glucose levels. Foods high in carbohydrates, such as sucrose, are not totally eliminated from the diet, but should be eaten in moderation because they are typically high in fat and lack vitamins, minerals, and fiber. The recommendations regarding fat content of the diabetic diet include both reducing the total percent of calories from fat sources to less than 30% of total calories and limiting the amount of saturated fats to 10% of total calories. Regarding protein, the meal plan may include the use of some non-animal sources of protein, like legumes and whole grains, to help reduce saturated fat and cholesterol intake. Hyperthyroidism, a common endocrine disorder, is a form of thyrotoxicosis resulting from an excessive synthesis and secretion of endogenous or exogenous thyroid hormones by a thyroid. The most common cause is Graves' disease. Graves' disease is the most common cause of hyperthyroidism. It is an autoimmune disorder that results from excessive output of thyroid hormones caused by abnormal stimulation of the thyroid gland by circulating immunoglobulins. This disease affects women 8 times more frequently than men, with onset usually between the 2nd and 4th decades. This disorder may appear after an emotional shock, stress, or an infection, but the exact significance of these relationships is not understood. The presenting symptom is often nervousness. These patients are often emotionally hyperexcitable, irritable, and apprehensive. They cannot sit quietly, and they suffer from palpitations. Their pulse is abnormally rapid at rest, as well as on exertion. They tolerate heat poorly and perspire unusually freely. The skin is flushed continuously, with the characteristic salmon color in Caucasians, and is likely to be warm, soft, and moist. A fine tremor of the hands may be observed, and patients exhibit exophthalmos, which is abnormal protrusion of one or both eyeballs, or as we call it, bulging eyes. Other manifestations include an increased appetite and dietary intake, weight loss, fatigability and weakness, amenorrhea, and changes in bowel function. In hyperthyroidism, medical management depends on the underlying cause and often consists of a combination of therapies, including antithyroid agents, radioactive iodine, and surgery. The treatment of hyperthyroidism is directed toward reducing the thyroid hyperactivity to relieve symptoms and preventing complications. The use of radioactive iodine is the most common form of treatment for Graves' disease. Beta-adrenergic blocking agents, like propanol or atenolol, are used as adjunctive therapy for symptomatic relief, particularly in transient thyroiditis. Surgical removal of the entire thyroid gland or part of it is a non-pharmacological agent. The 3 treatments, radioactive iodine therapy, antithyroid medications, and surgery, share the same complications: relapse or recurrent hyperthyroidism and permanent hypothyroidism. A nursing intervention is also improving nutritional status. Hypothyroidism affects all body systems, including the GI system. The appetite is increased, but may be satisfied by several well-balanced meals of small size, even up to 6 meals a day. Fluid and foods are selected to replace fluid loss through diarrhea and diaphoresis, and to control the diarrhea that results from increased peristalsis. Rapid movement of food through the GI tract may result in nutritional imbalance and further weight loss. To reduce diarrhea, highly seasoned foods and stimulants such as coffee, tea, and cola and alcohol are discouraged. High-calorie, high-protein foods are encouraged. The clinical manifestations of hypothyroidism are many. Extreme fatigue makes it difficult for the person to complete a full day's work or participate in usual activities. There are reports of hair loss, brittle nails, and dry skin are very common, and numbness and tingling of the fingers may occur. On occasion, the voice may become husky, and the patient may complain of hoarseness. Menstrual disturbances, such as menorrhagia or amenorrhea, may occur. Hypothyroidism affects women more frequently than men and occurs most often between ages 40 to 70 years of age. Severe hypothyroidism results in subnormal body temperature and pulse rate. The patient usually begins to gain weight even without increase in food intake, although he or she may be cachectic. The skin becomes thick, the hair thins and falls out, and the face becomes expressionless and mask-like. The patient often complains of being cold, even in a warm environment. The patient may be irritable and complain of fatigue, but as the condition progresses, the emotional responses are subdued. The mental process becomes dulled, and the patient appears apathetic. Speech is slow, the tongue enlarges, the hands and feet increase in size, and even deafness may occur. The patient frequently complains of constipation. Severe hypothyroidism is associated with elevated serum cholesterol level, atherosclerosis, coronary artery disease, and poor left ventricular function. The patient with hypothyroidism that is advanced is hypothermic and abnormally sensitive to sedative, opioid, and anesthetic agents, which must be administered with extreme caution. Patients with unrecognized hypothyroidism who are undergoing surgery are at increased risk for intraoperative hypotension, postoperative heart failure, and altered mental status. Causes of hypothyroidism include autoimmune disease, like Hashimoto's thyroiditis or post-Graves' disease, atrophy of the thyroid gland with aging, therapy for hyperthyroidism, which would include radioactive iodine or thyroidectomy, medications which include lithium, iodine compounds, or antithyroid medications, procedures such as radiation to head and neck and treatment for head and neck cancers, like lymphoma, can also produce hypothyroidism. Infiltrative diseases of the thyroid can also cause hypothyroidism. And then, of course, iodine deficiency and iodine excess can cause hypothyroidism. Treatment for hypothyroidism includes the medical management with the objectives of hypothyroidism to restore a normal metabolic state by replacing the missing hormone, as well as prevention of disease progression and complications. Synthroid or levothyroid is commonly prescribed for treating hypothyroidism and suppressing non-toxic goiters. Its dosage is based on the patient's serum thyroid-stimulating hormone concentration. If replacement therapy is adequate, the symptoms of myxedema disappear and normal metabolic activity is resumed. Although rare, if the disease progresses to myxedema coma, IV administration of T4 and T3 are recommended rather than T4 alone. T4 is administered IV until the patient is able to safely take T4 in oral form. T3 is administered IV until the patient is stable. Administration of high-dose glucocorticosteroids every 8 to 12 hours for 24 hours, followed by a low-dose therapy, is recommended until coexisting adrenal insufficiency is ruled out. Prevention of cardiac dysfunction is important, as well as prevention of medication interactions. Oral thyroid hormones interact with many other medications. There is a decrease in thyroid hormone absorption when patients are taking magnesium-containing antacids. Thyroid hormones may also decrease the pharmacological effects of digitalis. Doses of anticoagulant agents need to be decreased when beginning thyroid replacement because of the increased risk of bleeding. Even in small IV doses, hypnotic and sedative agents may induce profound somnolence, lasting far longer than anticipated and leading to narcosis. In adrenal hormone excess, there is Cushing syndrome. They call it hypercortisolism. Now, the causes are results from excessive rather than deficient adrenocortical activity. Cushing syndrome is commonly caused by the use of corticosteroid medications and is infrequently the result of excessive corticosteroid production secondary to hyperplasia of the adrenal cortex. However, overproduction of endogenous corticosteroids may be caused by several mechanisms, including a tumor of the pituitary gland that produces adrenocorticotropic hormone and stimulates the adrenal cortex to increase its hormone secretion despite production of adequate amounts. Primary hyperplasia of the adrenal glands in the absence of pituitary tumor is less common. Another less common cause of Cushing syndrome is the ectopic production of the adrenocorticotropic hormone by malignancies. Regardless of the case, the normal feedback mechanisms that control the function of the adrenal cortex become ineffective, and the usual diurnal pattern of cortisol is lost. Signs and symptoms of Cushing syndrome are primarily a result of oversecretion of glucocorticosteroids and androgens, although minimal corticosecretion may be affected as well. Clinical presentation can be obesity, hyperglycemia, glycosuria, hypertension, fluid and electrolyte disturbances, and may have psychosocial issues due to the body image. Clinical manifestations include when overproduction of the adrenal hormone occurs, arrest of growth, obesity, and musculoskeletal changes occur along with glucose intolerance. The classic picture of Cushing syndrome in the adult is that of a central type obesity with a fatty buffalo hump in the neck and supraclavicular areas, a heavy trunk, and relatively thin extremities. The skin is thin, fragile, and easily traumatized. Ecchymosis and striae developed. The patient complains of weakness. Sleep is disturbed because of altered diurnal secretion of cortisol. Excessive protein catabolism occurs, producing muscle wasting and osteoporosis. Kyphosis, backache, and compression fractures of the vertebrae may result. Retention of sodium and water occurs as a result of increased mineralocorticoid activity, producing hypertension and heart failure. The patient develops a moon-faced appearance and may experience increased oiliness of the skin and acne. Hyperglycemia or overt diabetes may result. The patient may also report weight gain, slow healing of minor cuts and bruises. In females of all ages, virilization may occur as a result of excess androgens. If Cushing syndrome is caused by pituitary tumors rather than tumors of the adrenal cortex, treatment is directed at the pituitary gland. Surgical removal of the tumor is the treatment of choice and has an 80% success rate. Radiation of the pituitary gland also has been successful. Adrenalectomy is the treatment of choice in patients with primary adrenal hypertrophy. Adrenal enzyme inhibitors such as metoprolol, cytodren, and lisodren may be used to reduce hyperadrenalism if the syndrome is caused by the ectopic ACTH secretion by a tumor that cannot be eradicated. If Cushing syndrome is a result of administration of corticosteroids, an attempt is made to reduce or taper the medication to the minimum dosage needed to treat the underlying disease process. Also, what is included is a nursing intervention for decreasing risk of injury, preventing the falls and fractures or other injuries to bones and soft tissues. Foods high in protein, calcium, and vitamin D are recommended to minimize muscle wasting and osteoporosis. Decreasing risk of infection is a nursing intervention, meaning the patient should avoid unnecessary exposure to others with infections. Preparing the patient for surgery if the patient is going for an adrenalectomy, if indicated, and the postoperative course. If Cushing syndrome is a result of a pituitary tumor, a transsphenoidal hypophysectomy may be performed. Diabetes and peptic ulcer are common in patients with Cushing syndrome. Therefore, insulin therapy and medication to prevent or treat peptic ulcer are initiated if needed. Encouraging resident activity is an important nursing intervention. Although the patient with Cushing syndrome experiences insomnia, weakness, fatigue, and muscle wasting, the nurse should encourage moderate activity to prevent complications of immobility and produce increased self-esteem. Promoting skin integrity with meticulous skin care is necessary to avoid traumatizing the patient's fragile skin. Improving body image, if treated successfully, with the major changes associated with Cushing syndrome disappear in time. The patient may benefit from discussion of the effect of the change that has had on their self-esteem concept and relationship with others. With hypocortisolism, or Addison's disease, it's an adrenocortical insufficiency. It occurs when adrenal cortex function is inadequate to meet the patient's need for cortical hormones. Autoimmune or idiopathic atrophy of the adrenal glands is responsible for the majority of cases. Other causes include surgical removal of both adrenal glands and infection of the adrenal glands. Tuberculosis and histoplasmosis are the most common infections that destroy adrenal gland tissue. Although autoimmune destruction has replaced tuberculosis as the principal cause of Addison's disease, tuberculosis should be considered in the diagnostic workup. Therapeutic use of corticosteroids is the most common cause of adrenocortical insufficiency. Symptoms of adrenocortical insufficiency may result from the sudden cessation of exogenous adrenocortical hormone therapy, which suppresses the body's normal response to stress and interferes with normal feedback mechanisms. The clinical manifestations with Addison's disease is characterized by muscle weakness, anorexia, GI symptoms, fatigue, emaciation, dark pigmentation of the mucous membranes and the skin, especially of the knuckles, knees, and elbows, hypotension, and low blood glucose, low serum sodium, and high serum potassium levels. Depression, emotional liability, apathy, and confusion are present in about 20 to 40% of patients. In severe cases, the disturbance of sodium potassium metabolism may be marked by depletion of sodium and water and severe chronic dehydration. As the disease progresses, Addisian crisis develops. This condition is characterized by hypotension, cyanosis, fever, nausea, vomiting, and classic signs of shock. The patient may have pallor, complain of headache, abdominal pain, and diarrhea, and may show signs of confusion and restlessness. The treatment and medical management is directed towards combating circulatory shock, restoring blood circulation, administering fluids and corticosteroids, monitoring vital signs, and placing the patient in a recumbent position with legs elevated. Hydrocortisone, or Solu-Cortef, is administered by IV, followed by a 5% dextrose and normal saline. Antibiotics may be administered if infection has precipitated adrenal crisis. Oral intake may be initiated as soon as tolerated. IV fluids are gradually decreased after oral fluid intake is adequate to prevent hypovolemia. If the adrenal gland does not regain function, the patient needs lifelong replacement of corticosteroids and mineralocorticoids to prevent recurrence of adrenal insufficiency. During stressful procedures or significant illness, additional supplemental therapy with glucocorticoids is required to prevent Addison crisis. In addition, the patient may need to supplement dietary intake with salt during GI losses of fluids through vomiting and diarrhea. The concept of nutrition includes the exemplars obesity, malnutrition, iron deficiency anemia, dysphagia, cardiovascular, diabetes mellitus 2, malabsorption. Within the malabsorption, there is also gastrostomy and enteral feedings. The reading you are responsible for, and we will go over briefly the nutrition with the exemplars associated with it. Nutrition is important to maintain health and to prevent disease and death. When illness or injury occurs, optimal nutrition is essential for healing and for resisting infection and other complications. Components of a nutritional assessment: there is a sequence of assessment parameters that may vary. However, evaluation of nutritional status includes these following methods: measurement of body mass index, or the BMI, waist circumference, biochemical assessment, clinical examination findings, and dietary data. The measurement of BMI and waist circumference is recommended to determine if a patient is obese. The BMI ratio based on base body weight and height. The obtained value is compared to the established standards. The BMI is highly correlated with body fat, although increased lean body mass or a large body frame can also increase the BMI. In nutrition, it's important to consider lifespan considerations. Adolescence is a time of critical growth and when lifelong eating habits are established. Nutritional assessment is particularly important during this time period. It is vital to assess for obesity in adolescents to prevent complications from obesity as they enter adulthood. Adolescent girls are at a particular nutritional risk because iron, folate, and calcium intakes are below recommended levels, and they are less physically active group compared to adolescent males. Adolescents with other nutritional disorders such as anorexia and bulimia have a better chance of recovery if these disorders are identified and treated in the adolescent years rather than the adulthood. In nutrition, the older adult has a nutritional assessment that we must consider. Nutritional screening in the older adult is the first step in maintaining adequate nutrition and replacing nutrient losses to maintain the individual's health and well-being. Inadequate dietary intake in older adults may result from physiologic changes in the GI tract, socioeconomic factors, drug interactions, disease, and excessive use of alcohol, and poor dentation or missing teeth. Even older adults may be nutritionally at risk because of decreased odor perception, poor dental health, limited ability to shop and cook, financial hardship, and the fact that they often eat alone. In addition, reduction in exercise with age without concomitant changes in carbohydrate intake places the older adult at risk for obesity. There is an increased need for good nutrition, but a decreased need for calories. They also have a decline in renal function and a decreased ability to maintain fluid and electrolyte balance. In nutrition, the exemplar malnutrition is a concern. There are health consequences that are associated with malnutrition: wound healing, susceptibility to infection, longer hospital stays, and prolonged confinement to bed. There are certain signs and symptoms that suggest possible nutritional deficiency, such as muscle wasting, poor skin integrity, loss of subcutaneous tissue, and obesity. These are easy to note because they are specific. Other physical signs may be subtle and must be carefully assessed. For example, certain signs that appear to indicate nutritional deficiency may actually reflect other systemic conditions, like endocrine disorders or infectious disease. Others may result from impaired digestion, absorption, excretion, or storage of nutrients in the body. Disorders caused by nutritional deficiency, overeating, or eating unhealthy meals are among the leading cause of illness and death in the United States today. Examples of health problems associated with poor nutrition include obesity, osteoporosis, cirrhosis, diverticulitis, and eating disorders. In the concept nutrition, we'll be discussing iron deficiency anemia. Anemia is a condition in which the hemoglobin concentration is lower than normal. It reflects the presence of fewer than normal number of erythrocytes within the circulation. As a result, the amount of oxygen delivered to body tissues is also diminished. Anemia is not a specific disease state, but a sign of an underlying disorder. Anemia can be classified in several ways. A physiologic approach classifies anemia according to whether the deficiency in erythrocytes is caused by a deficit in their production, by their destruction, or by their loss. In your textbook, page 901, Hinkle, you have a chart, table 33.1, that has a classification of anemias. We will be focusing on the iron deficiency. In a CBC with iron deficiency anemia, there is low MCV and low reticulocytes. Other findings are low iron, low percent of saturation, and low ferritin. With this, clinical manifestations include fatigue. Also pica. Pica is the persistent eating of substances with no nutrition, such as dirt or paint or even starch. Within the concept of nutrition, there is cardiovascular as an exemplar. See page 732 in your Hinkle textbook, chart 27.1, titled Risk Factors, Coronary Artery Disease. Now, there are non-modifiable risk factors, and there are modifiable risk factors. A non-modifiable risk factor is a circumstance over which a person has no control. A modifiable risk factor is one over which a person may exercise control, such as change in a lifestyle or personal habit, or by using medication. A risk factor may operate independently or in tandem with other risk factors. The more risk factors a person has, the greater the likelihood of coronary artery disease. Non-modifiable risk factors are family history of coronary artery disease, increasing age, gender, men develop coronary artery disease at an earlier age than women, and race, higher incidence of heart disease in African Americans than in Caucasians. Modifiable risk factors include hyperlipidemia, and within that, high, low-density lipoprotein, smoking, hypertension, diabetes, metabolic syndrome, obesity, and physical inactivity. In the cardiovascular exemplar, prevention is essential. Controlling cholesterol abnormalities will benefit the patient in having less cardiovascular disease. The way we can control cardiovascular levels and the levels that we want is a low-density lipoprotein, or LDL, a high-density lipoprotein, HDL, low triglycerides, and a diet that has low saturated fat and high fiber. LDL is the target of current therapy because of its strong association with advancing coronary artery disease. The total cholesterol level is also a clear predictor of coronary events. High-density lipoprotein is known as good cholesterol because it transports other lipoproteins, such as low-density lipoproteins, to the liver, where they can be degraded and excreted. Because of this, a high HDL level is a strong negative risk factor for heart disease. It protects against heart disease. With continuing in the exemplar cardiovascular, prevention continues. Dietary measures. They provide recommendations of the therapeutic lifestyle changes diet, which is a diet low in saturated fat and high in soluble fiber. These general recommendations may need to be adjusted for the individual patient who has other nutritional needs, such as the patient who has diabetes. Physical activity is essential. Management of an elevated triglyceride level focuses on weight reduction and increased physical activity. Regular moderate physical activity increases HDL levels and reduces triglyceride levels, decreasing the incidence of coronary events and reducing overall mortality risk. Medications can be utilized if diet alone cannot normalize serum cholesterol levels. Medications can have a synergistic effect with the prescribed diet and control cholesterol levels. Lipid-lowering medications can reduce coronary artery disease mortality in patients with elevated lipid levels and in at-risk patients with normal lipid levels. Cigarette smoking contributes to the development and severity of coronary artery disease. A person who can have a cessation of smoking will decrease the risk for heart disease. Person at increased risk for heart disease is encouraged to stop tobacco use through any possible means, whether it be educational programs, counseling, consistent motivation and reinforcement messages, support groups, and medications if needed. Managing hypertension is defined as blood pressure measurements that repeatedly exceed 140/90 millimeters of mercury. The risk of cardiovascular disease increases as blood pressure increases, and people with a blood pressure greater than 120/80 are considered pre-hypertensive and at risk. Early detection of high blood pressure and adherence to a therapeutic regimen can prevent the serious consequences associated with untreated elevated blood pressure, including coronary artery disease. Controlling diabetes is known to help prevent the development of heart disease. For many patients with diabetes, cardiovascular disease is identified as the cause of death. Hyperglycemia fosters dyslipidemia, increased platelet aggregation, and altered blood cell function, which can lead to thrombosis formation. These metabolic alterations may impair endothelial cell dependent vasodilation and smooth muscle function, promoting the development of atherosclerosis. The concept nutrition with the exemplar diabetes mellitus type 2 focuses on meal planning. Caloric requirements are based on age, gender, height, and weight, but the caloric distribution depends on carbohydrates, fats, proteins, and fiber. Carbohydrates should consist of 50 to 60% of the caloric requirements, fat 20 to 30%, protein 10 to 20%, and fiber 25 grams a day. With the concept of nutrition and the exemplar malabsorption, we'll be now discussing malabsorption with the infant or child. Short bowel syndrome is a clinical syndrome of nutrient malabsorption and excessive intestinal fluid and electrolyte losses that occurs following massive small intestinal loss or surgical resection. The most common causes of short bowel syndrome are necrotizing enterocolitis, small intestinal atresia, gastroschisis, malrotation with volvulus, and trauma to the small intestine. The extent of the malabsorption experienced by an individual is dependent upon the extent of the duodenal, ileal, or jejunal loss and the length of the small intestine loss, as well as the type. In malabsorption for the infant child with the short gut syndrome, nursing management includes total parenteral nutrition for long-term, enteral feeding, administering vitamin and mineral supplements, administering antidiarrheals, and administering antibiotics per order. The child with short bowel syndrome is at risk for chronic complications. The goals of therapeutic management are to minimize bacterial overgrowth and to maximize the child's nutritional status. The antibiotics may be used to control that bacterial overgrowth. Vitamin and mineral supplementation is necessary because the small intestine is usually where fat-soluble vitamins, calcium, magnesium, and zinc are absorbed. Antidiarrheal agents such as loperamide and gastric acid suppressive medications may be used to decrease stool output. Many children with short bowel syndrome require total parenteral nutrition for extended periods to achieve adequate growth. Gastrostomy and enteral feedings are exemplar under nutrition. Gastrointestinal intubation is the insertion of a flexible tube into the stomach or beyond the pylorus into the duodenum or the jejunum. The tubes may be inserted through the mouth, the nose, or the abdominal wall. The tubes are obviously of various diameters and length depending on their intended use. The purpose of GI intubation may be performed in order to decompress the stomach and remove gas and fluid, lavage, which is flush with water or other fluids and remove ingested toxins or other harmful materials, diagnose GI disorders, administer tube feedings, fluids, and medications, compress a bleeding site, or aspirate GI contents for analysis. The different types of tubes depend on the diagnosis. Within these tubes, we do nursing management. We prepare the patient prior to the insertion to promote cooperation during the procedure. Once placed, we confirm placement. To ensure patient safety, it's essential to confirm the tube has been placed correctly. The tip of the tube may be in the esophagus, stomach, or small intestine. It may also inadvertently be inserted in the lungs, most commonly in the right main stem bronchus. Inappropriate placement may occur in patients with decreased level of consciousness, confused mental states, poor absent gag, or cough reflexes, or agitation during insertion. Also, what must be assessed is clearing tube obstruction. If it's difficult to instill withdraw warm water into a clogged feeding tube, several declogging steps can be taken, including warm water penetration, milking the tube, infusing digestive enzymes, and employing mechanical declogging devices. When the tube is first noted to be clogged, a 30 to 60 ml syringe should be attached to the end of the tube and any contents aspirated and discarded. Then the syringe should be filled with warm water, attached to the tube again, and a back and forth motion initiated to help loosen the clog. Clearing tube obstructions is essential so that medications can be input or drainage can be expelled. Also, the nurse must provide oral and nasal hygiene. It is essential to have regular conscious oral and nasal hygiene because the tube causes discomfort and pressure and may be in place for an extended length of time. The nose is inspected daily for irritation and the tape is changed every 2 to 3 days. The nurse must also monitor and manage potential complications. Patients with these NG intubations are susceptible to a variety of problems, including fluid volume deficit, pulmonary complications, and tube-related irritations. These potential complications require careful ongoing assessment. There are also collaborative potential problems with gastrostomy and enteral feedings. There could be wound infections, whether it be wounds within the body or wounds at the site. Cellulitis, that is mostly at the site that there could be cellulitis of where the tube is inserted, whether it be nares, oral, or abdominal. Leakage at the site, gastrointestinal bleeding, and premature dislodgement of the tube. In the gastrostomy and enteral feedings, patient education is important. You can find a patient education chart, 45-7, page 1233, in your Hinkle ebook. Troubleshooting for mechanical difficulties is an intervention that should be utilized. Mechanical problems can arise with the infusion pump or catheter site. The patient should know the external length of the catheter, and the measurement is used as a comparison if dislodgement is suspected. The patient should also know a list of instructions on how to recognize catheter problems, including the leakage, loose caps, blood clots, and dislodgement, and what to do for each problem. Recognizing metabolic complications is essential. The patient is given a list of signs and symptoms that indicate metabolic complications like neuropathies, mentation changes, diarrhea, nausea, skin changes, decreased urine output, and directions on how to contact a home health care nurse or physician if these complications occur. Obtaining psychosocial support of home parenteral nutrition are as important as the physiologic and technical concerns, because the patients must cope with the loss of eating and with changes in lifestyle brought on by sleep disturbances related to frequent urination during nighttime infusions. So major psychologic reactions include depression, anger, withdrawal, anxiety, impaired self-image, and a successful parenting nutrition program depends on the patient's and family's motivation, emotional stability, and technical competence. Health promotion is the concept and obesity is the exemplar. Promoting nutrition is important to educate to decrease obesity. Nutritional needs are increased during adolescence, though, due to accelerated growth and sexual maturation. Adolescents may appear to be hungry constantly and need regular meals and snacks with adequate nutrients to meet the body's anaerobic requirements. Multiple factors influence the adolescent's diet and eating habits. Now, there are nutritional needs for teenagers. They have a need for increased calories, zinc, calcium, and iron for growth. However, the number of calories needed for adolescents depends on the teen's age and activity level as well as growth patterns. Promoting healthy eating habits will last into the lifetime. The nurse understands normal growth and development of the adolescent and provides guidance that fits the quest for independence and the need for teens to make their own choices. They assess eating habits and diet preferences for the adolescent. The assessment should include evaluation of food from different food groups that the adolescent eats each day. There also should be prevention of developing of overweight and obesity. Although obesity has increased in all segments of the U.S. population, there are differences specific to race, ethnicity, and socioeconomic status. The prevalence of obesity is highest in Hispanic and African American teens between the ages of 12 and 19 years. But the increase in obesity in adolescents has led to increases in hypertension, heart disease, and type 2 diabetes. Influential factors causing obesity include food choices, eating practices, and lack of exercise. Research has indicated that the percentage of children that eat breakfast decreases with age, and that by adolescence, only 77% of 12 to 19-year-olds even eat breakfast. This runs also into being an adult. So to help with decreasing obesity, nurses need to be aware to teach factors that lead to obesity. And nurses should be recommending keeping a food diary to determine current food patterns, proper nutrition and healthy food choices, good eating habits, decreasing fast food intake, having patients participate in physical activity every day. Parents and adolescents together can be exercising more at home, and decrease computer use and television watching. The concept tissue integrity includes the exemplars dermal ulcer, impetigo, psoriasis, wounds, which include surgical and traumatic, tinea pedis, candida, and pediculosis capitis, or lice. Once again, please be aware that the reading in the reading list is you are responsible to complete. The exemplar impetigo is a bacterial skin infection. Impetigo is a superficial infection of the skin caused by staphylococci, streptococci, or multiple bacteria. Bullous impetigo, a more deep-seated infection of the skin, is caused by Staphylococcus aureus. It's characterized by the formation of a bullae. The exposed areas of the body, face, hands, neck, and extremities are most frequently involved. Now, impetigo is contagious and may spread to other parts of the patient's skin or to other members of the family who touch the patient or use towels or combs that are soiled with the exudate of the lesions. Impetigo is seen in people of all races and ages. It is particularly common in children living in poor hygienic conditions. Now, chronic health problems, poor hygiene, and malnutrition may predispose an adult to impetigo. The clinical manifestations are lesions that are most commonly seen on the face or extremities. They begin as small red macules, which quickly become discrete, thin-walled vesicles that rupture and become covered with a loosely adherent honey yellow crust. Now, these crusts are easily removed to reveal smooth red moist surfaces on which new crusts soon develop. Now, with the medical management, topical antibiotic therapy is usually prescribed when the disease is limited to a small area. Lesions are first soaked or washed with soap solution to remove the central site of bacterial growth, giving the topical antibiotic an opportunity to reach the infected site. After the crusts are removed, the prescribed topical antibiotic cream is applied. Now, gloves should be worn when providing patient care. Systemic antibiotics can be prescribed to treat infections that are widespread or in cases where they are systemic manifestations and if a fever is present. The nursing management includes when the nurse educates the patient and family to bathe at least once daily with bactericidal soap. Cleanliness and good hygiene practices help to prevent the spread of the lesions from one skin area to another and from one person to another. Patients and family members must be educated to practice hand hygiene every time after a lesion is touched. Each person should have a separate towel and washcloth. Because impetigo is contagious, infected people should avoid contact with other people until the lesions heal. The exemplar psoriasis is considered one of the most common chronic non-communicable skin diseases. It's characterized by the appearance of silvery plaques that most commonly appear on the skin over the elbows, knees, scalp, lower back, and buttocks. Although lesions may appear anywhere, including the oral cavity, eyes, including the lids, conjunctiva and corneas, and joints. Onset can occur at any age, with a median onset at 28 years. It is more prevalent among women and Caucasians and among persons who are obese. It is thought that most patients with psoriasis have a genetic predisposition to develop the disease. Psoriasis has a tendency to improve and then recur periodically throughout life. The pathophysiology of psoriasis, the current evidence supports an autoimmune basis. Periods of emotional stress and anxiety aggravate the condition, and trauma, infections, and seasonal and hormonal changes may also serve as triggers. The clinical manifestations may range in severity from a cosmetic source of annoyance to a physically disabling and disfiguring disorder. The lesions appear as red, raised patches of skin covered with silvery scales. The scaly patches are formed by the buildup of living and dead skin. If the scales are scraped away, the dark red base of the lesion is exposed, producing multiple bleeding points. The patches are not moist and may be pruritic. In many cases, the nails are also involved with pitting, discoloration, crumbling beneath the free edges, and separation of the nail plate. Now, medical management, the goal is to slow the rapid turnover of the epidermis to promote resolution of the psoriatic lesions and to control the natural cycles of the disease. There is no known cure. The therapeutic approach should be one that the patient understands, because they will be the ones who are providing the interventions and care. It should be cosmetically acceptable and minimally disfiguring of a lifestyle. Treatment involves the commitment of time and effort by the patient and possibly family. Any precipitating or aggravating factors are addressed. An assessment made of the lifestyle, because psoriasis is significantly affected by stress. Gentle removal of scales is an important principle of psoriasis treatment. This can be accomplished by taking baths with added oils. There can be pharmacological therapy. There can be topical, phototherapy, and systemic. Pediculosis capitis, or head lice, is very easily transmitted. It is usually with direct contact with hair of infested people, or less commonly can be with personal belongings such as combs and hats of those infested. The incubation period from laying to eggs to hatching is 6 to 10 days. So adult lice will appear 2 to 3 weeks later. Now, the clinical manifestations or extreme pruritus is the most common symptom. The adult eggs or nits may be seen, especially behind the ears and the nape of the neck of the patient. The diagnosis is made by the identification of those eggs, and lice with the naked eye is possible. Adult lice are rarely seen, but can be seen. The treatment is to wash hair with a particular side, such as permethrin, or they call it Nix. Careful instructions on proper use of any product should be given, and strict adherence to applications is encouraged. Retreatment is usually recommended depending on treatment used. Now, detection of living lice 24 hours after treatment suggests incorrect use, or heavy infestation, reinfestation, or resistant to treatment. Now, these patients will be in contact precautions because it is easily transmitted. After treatment, we check the hair and comb the nits and lice from hair shafts every 2 to 3 days to prevent reinfestation. We also can manually do with our hands by pulling with the tips of our nails the nits. Now, control measures are to household and other close contacts should be examined, and if infested, they're treated. Bedmates should be treated prophylactically. Now, head lice do not survive long once they have fallen off, and most children can be treated effectively without treating their clothing and bedding, but to help avoid reinfestation, Disinfection of clothing, headgear, pillowcases, towels, and other items used by the individual within the last 2 days should be washed in hot water and dried on the hot cycle. Soaking combs and hairbrushes in the pediculicide shampoo or hot water is also recommended. Lice infestation is not a sign of poor hygiene. All socioeconomic groups are affected. The concept mobility will include the exemplars hip fracture, disuse syndrome, joint replacement, osteoarthritis, and osteoporosis. We will discuss a few of these. The exemplar joint replacement is under the category of the mobility concept. Patients with severe joint pain and disability may undergo joint replacement. Conditions contributing to joint degeneration include osteoarthritis, rheumatoid arthritis, trauma, and congenital deformity. Some fractures, like a fracture of the femoral neck fracture, may cause disruption of the blood supply and subsequent death of tissue due to insufficient blood supply, which is called avascular necrosis. It also has to do with management with joint replacement may be elected over an open reduction. Joints frequently replaced include the hip, knee, and finger joints. More complex joints like the shoulder, elbow, wrist, and ankle are replaced less frequently. Nursing interventions when there is a joint replacement has to do with assessment of the patient and preoperative management. Those are aimed at having the patient in optimal health at the time of surgery. Nursing interventions also include preventing deep vein thrombosis. Patients having orthopedic surgery are particularly at risk for deep vein thrombosis and pulmonary embolism. The use of medications that increase the risk of clotting, such as certain hormones and NSAID drugs, may be discontinued a week before surgery. Assessing the neurovascular status of the extremity undergoing the joint replacement is important because post-operative assessment data are compared with pre-operative assessment data to identify changes and any arterial impairment to the affected extremity. Another nursing intervention is preventing infection. Any infection presenting 2 to 4 weeks before planned surgery may result in postponement of a surgery. Preoperative skin preparation, such as showers with antiseptic soap, frequently begins 1 or 2 days before the surgery. Culturing of the joint during surgery may be important in identifying and treating subsequent infections. The other intervention is managing pain. Assessment of the patient's pain preoperatively and any cultural and value preference are important components related to the control of pain following joint surgery. Assessing the patient's level of understanding of surgery and explaining what to expect can improve outcomes. A patient receiving total hip arthroplasty or hip replacement has many nursing diagnoses and nursing interventions. There is Chart 41-8, Plan of Nursing Care, in your Hinkle ebook, page 1119. Our nursing interventions would include assessing the patient for pain, asking the patient to describe that discomfort, and using pain-modifying techniques, after which we evaluate and record the discomfort. Also, nursing interventions that are included are maintaining proper position of the hip joint, which would be abduction, neutral rotation with limited flexion. We want to keep pressure off the heel. We want to instruct and assist in position changes and transfers. We offer encouragement and support exercise regimen. Also included is monitoring vital signs and observing for shock. We want to prevent hemorrhage or be aware if it is starting to happen. We note character and amount of drainage, and we notify the surgeon if the patient develops shock or excessive bleeding, and we prepare to administer fluids or blood component therapy and medications. We also monitor the hemoglobin and hematocrit values. We assess our neurovascular. We assess the extremity for color and temp, cap refill, edema, swelling, elevate the lower extremity, assess for deep throbbing, assess for pain on passive flexion, assess for change in sensation and numbness, and assess ability to move the foot and toes, assessing pedal pulses on both feet, and notifying the surgeon if altered neurovascular status is noted. The exemplar osteoarthritis is a degenerative joint disease. Osteoarthritis is a non-inflammatory degenerative disorder of the joints. It is the most common form of joint disease and is routinely referred to as a degenerative joint disease. It is classified as either primary, which is idiopathic, with no prior event or disease related to the osteoarthritis, or secondary, resulting from previous joint injury or inflammatory disease, similar to rheumatoid arthritis. Unlike most of the disease processes, the pathophysiology of primary osteoarthritis does not involve autoimmunity or inflammation. It can occur as the end result of an autoimmune disorder where joint destruction occurs. Another distinguishing characteristic is that it's limited to the affected joints. There are no systemic symptoms associated with it. Osteoarthritis often begins in the third decade of life and peaks between the fifth and sixth decades. By 40 years of age, 90% of the population has degenerative joint changes in their weight-bearing joints, even though clinical symptoms are usually absent. Women, especially those who are Hispanic or African American, are more commonly affected. The prevalence of osteoarthritis is between 50 to 80% in older adults. Although osteoarthritis is usually thought of as a disease of aging, it also affects younger patients and results in significant losses in work-related productivity and higher costs. Now, the pathophysiology is all joints consist of bone, to which articular cartilage is attached. This articular cartilage is lubricated and smooth tissue that protects the bone from damage with physical activity. Between the articular cartilage of the bones forming the joint is a space called the joint space that allows for movement. To aid in the fluidity, each joint contains synovial fluid to help lubricate and protect the joint's movement. Now, with osteoarthritis, the articular cartilage breaks down, leading to progressive changes to the underlying bone and eventual formation of bone spurs, or osteophytes, that protrude into the joint space. The result is that the joint space is narrowed, leading to decreased joint movement and the potential for more damage. The clinical manifestations are pain, stiffness, and functional impairment. The joint pain is usually aggravated by movement or exercise and relieved by rest. On physical exam, the affected joint may be enlarged with a decreased range of motion. Although osteoarthritis occurs most often in weight-bearing joints, like the hips, knees, cervical, and lumbar spine, joints are also involved, causing bony enlargements. Crepitus may be palpated, especially over the knee. Joint effusion, a sign of inflammation, is usually mild, and no systemic manifestations are found. Medical management are to decrease pain and stiffness and to maintain or, when possible, improve joint mobility. Exercise has been found to prevent osteoarthritis progression and decrease symptoms. Along with exercise, weight loss, which in turn decreases excess load on the joint, can also be extremely beneficial. Occupational physical therapy can help the patient. The exemplar osteoporosis is a metabolic bone disorder. It is the most prevalent bone disease in the world. The consequence of osteoporosis is bone fracture. It is projected that 1 of every 2 Caucasian women and 1 of every 5 men will have osteoporosis-related fractures at some point in their lives. Now, prevention can be essential. Peak adult bone mass is achieved between the ages of 18 and 25 years in both men and women and is affected by genetic factors, nutrition, physical activity, medications, endocrine status, and general health. Now, risk factors for osteoporosis and their effects on bone remodeling and maintenance are noted. Primary osteoporosis occurs in women after menopause, usually by age 51, and in men later in life. Failure to develop optimal peak bone mass and low vitamin D levels contributes to the development of osteopenia without associated bone loss. Early identification of at-risk teenagers and young adults, increased calcium and vitamin D intake, participation in regular weight-bearing exercise, and a modification of lifestyle, which includes reduced use of caffeine, cigarettes, carbonated soft drinks, and alcohol, are interventions that decrease the risk of fractures and associated disability later in life. There is a chart in your textbook 1141, page chart 42-6, that discusses preventative measures for osteoporosis. Preventative home care checklist measures can include listing that risk factor, identifying calcium and vitamin D rich foods, consuming diet with adequate calcium, engaging in weight-bearing exercising daily, and once again, those modifying lifestyle choices to avoid that smoking, alcohol, caffeine, and carbonated beverages. Now, menopausal and postmenopausal women, in addition to what we just discussed, may have to have calcium supplements, continue to engage in exercise and improve balance, demonstrate good body mechanics, have pharmacological agents to maintain and enhance bone mass, and assess home environment for hazards contributing to falls. Now, men, we need to list risk factors associated with osteoporosis in men, including medications like corticosteroids, anti-seizure medications, and aluminum-containing antacids, also chronic diseases like kidney, lung, and GI, and undiagnosed low testosterone levels. They need to talk with primary provider about the use of medications to enhance bone mass or to correct testosterone deficiency. The concept cognition includes the exemplars Alzheimer's disease or dementia, which we'll also discuss vascular dementia, delirium, and Down syndrome. Alzheimer's disease is the 5th leading cause of death for older adults. It is a progressive, irreversible, degenerative neurologic disease that begins insidiously and is characterized by gradual losses of cognitive function and disturbances in behavior and affect. It can occur in people as young as 40 years of age, but is uncommon before 65 years of age. Although the prevalence increases dramatically with increasing age, it affects as many as half of those 85 years and older. It is to be noted that it is not a normal part of aging. Without a cure or any preventative measures, it is estimated that 13.4 million Americans will have this disease by 2050. With the pathophysiology, there are specific neuropathogenic and biochemical changes that are found in patients with Alzheimer's disease. These include neurofibrillary tangles, or senile or neurotic plaques. The neuronal damage occurs primarily in the cerebral cortex and results in decreased brain size. Similar changes are found in the normal brain tissue of older adults, although to a lesser extent. Cells that use the neurotransmitter acetylcholine are primarily affected by Alzheimer's disease. At the biochemical level, the enzyme active in producing acetylcholine, which is specifically involved in memory processing, is decreased. Now, the clinical manifestations show in the early stages are forgetfulness and subtle memory loss. Patients may experience small difficulties in work or social activities, but have adequate cognitive function to compensate for the loss and continue to function independently. With the further progression, the deficits can no longer be concealed. Forgetfulness is manifested in many daily actions. Patients may lose their ability to recognize familiar faces, places, and objects, and they may become lost in a familiar environment. They may repeat the same stories because they forget that they have already told them. The ability to formulate concepts and think abstractly disappears. On a hot day, a patient may decide to wade in the city fountain fully clothed. Patients may have difficulty with everyday activities such as operating simple appliances and handling money. Personality changes are also usually evident. They may become depressed, suspicious, paranoid, hostile, and even combative. With the medical management, the primary goal is to manage the cognitive and behavioral symptoms. There is no cure. There are several medications that have been introduced to slow the progression of the disease. The cholinesterase inhibitors, like Aricept and Exelon, enhances acetylcholine uptake in the brain, thus maintaining memory skills for a period of time. These and other medications are used for mild to moderate symptoms. Cognitive ability may improve within 6 to 12 months of therapy. However, cessation of the medications results in disease progression and cognitive decline. The behavioral problems such as agitation and psychosis can be managed by behavioral and psychologic therapies. Associated depression and behavioral problems can also be treated pharmacologically if other interventions fail. Because symptoms change over time, all patients with Alzheimer's disease should be reevaluated routinely. In Alzheimer's disease, nursing management plays an important role in the recognition of dementia, particularly in hospitalized older adults, by assessing for signs, repeating or asking the same thing over and over, or getting lost. During the nursing admission assessment, we assess for these symptoms. Nursing interventions are aimed at promoting patient function and independence for as long as possible. Other important goals include promoting the patient's physical safety, promoting independence and self-care activities, reducing anxiety and agitation, improving communication, providing for socialization and intimacy, providing adequate nutrition, and promoting activity balanced with rest. Supporting and educating family caregivers is also an important role that nurses play. These nursing interventions apply to all patients, regardless of the cause. The emotional burden on the families of patients with all types of dementia is enormous. The physical health of the patient is often very stable, and the mental degeneration is gradual. Family members are faced with numerous difficult decisions, such as when the patient should stop driving, when to assume responsibility for the patient's financial affairs. Now, aggression and hostility exhibited by the patient are often misunderstood by families or caregivers who feel unappreciated, frustrated, or angry. Feelings of guilt, nervousness, and worry contribute to the caregiver with fatigue, depression, and family dysfunction. The Alzheimer's Association is a coalition of family members and professionals who share the goals of family support and service, education, research, and advocacy. There are family support groups and respite care and adult daycare that can be available through different community resources. Respite care is commonly provided service in which caregivers can get away from the home for short periods while someone else tends to the needs of the patient. Caregivers must learn to distinguish between obligations from those that are not completely necessary. They do not leave the patient home alone, and they may be taught balance and sustainability between the care of self and the patient. With vascular dementia, it is associated with cerebral vascular disease in the form of multiple infarcts or strokes, a single larger infarct, or small vessel disease. It affects approximately 10 to 20% of people with dementia. The rate is higher in men than women and tends to have a more abrupt onset than Alzheimer's disease. Multifarct dementia, the most common form of vascular dementia, has an unpredictable course and is characterized by variable impaired depending on the affected sites of the brain. Because vascular dementia is associated with hypertension and cardiovascular disease, risk factors such as hypercholesteremia, history of smoking, and diabetes are similar. Prevention and management are also similar. Therefore, measures to decrease blood pressure and lower cholesterol levels may prevent future infarcts.